Dear colleagues, welcome to my hospital at Ranaghat, West Bengal, India. This is a very hard cataract. You can see the black appearance of the cataract. You can call it Cataracta Nigra. I've taken up this case for surgery. Let us observe the surgical steps. By this time I have made the main incision on the posterior aspect of the limbus. One side port has been made, and this is another side port on the right side of the main incision. So two side ports and on main incisions have been made, and now the anti-capsule is being stained with trypan blue dye underneath an air bubble, because in such cases contrast is very less. To get some contrast, we should stain the anti-capsule with trypan blue dye. One good thing in this case is the pupil is nicely dilated. Now this is hydroxypropyl methyl cellulose in the anterior chamber and over the corneal epithelium to get better visibility. Now Capsulorhexis. The anti-capsule is incised with a 26 case bane needle. I raise a nice flap which is very easy to hold, and now I take the Utata forceps. I go anti-clockwise. This depends on you. If you are comfortable with clockwise movement, you must do that. You must follow your natural hand movements. The rhexis is almost complete. All the time keep an upward push on the anterior lip of the main incision. Use the anterior lip as the fulcrum and go all around and do this rhexis. The rhexis is nice. It is round, but there is a big but in this case. This rhexis is not adequate for this hard cataract. So I am enlarging the rhexis a bit. I have incised the rhexis margin at 2 o'clock with a vitreous scissor. And now trying to hold this. After 3 attempts I could hold it and enlarged it a little bit. And this small amount of enlargement will help me in surgery. So friends, in hard cataracts, always try to do a large rhexis. If it becomes small, enlarge it at some area. Now hydrodissection has to be done with extreme caution. Don't inject a lot of fluid. Inject small amount of fluid and depress the nucleus. Tap the nucleus to spread the fluid, and then after hydrodissection at multiple points, rotate the nucleus. Inject visco again. You can use soft shell technique in this case, that is, use a dispersive viscoelastic substance. Chondroitin sulfate is the best, and then beneath that dispersive viscoelastic substance, use a cohesive and do the rhexis. Now, which technique is best for this hard cataract? Yes, it is crater and chop. Why? Because if I try to chop this nucleus directly, I may be successful, but it may not be safe. So better to make a pit, better to make a crater and debulk the hardest core of these type of cataracts. You can see some cavitation bubbles because my ultrasonic energy that I have used is very high to make this crater. I am in phaco on mode. Ultrasonic energy set is 85%. Flow rate is only 20 ml per minute. Vacuum is only 60 millimeter of mercury for this sculpting and for making this crater. And now I make the bevel off. So far I was able to make the bevel off, do some more sculpting, go at a deeper plane, and now I go to phaco 2 mode. I ask my assistant to change the mode, phaco 2 mode, where the vacuum is very high. In this case I have used 450 vacuum, and I engage the tip into the substance of the nucleus, go for some distance and crack. You can see that how gently I am separating the pieces. I come to opposite side. I don't try to crack it whole from one side. Come to opposite side, and along the initial crack you can see that I have been able to divide the nucleus totally into 2 halves. This is the beauty of crater and chop in such hard cataracts. And this is the technique for hard cataracts. If you have a mid-range machine like Oatley or Abbott, if you have a very high-range machine like Centurion, where the hard cataracts can be cut like butter, then you can do divide and conquer technique. But you have to afford that kind of machine. If you have an average machine like this, Oatley, which is affordable to many of us, or Abbott, Intuitive, whatever, you have to find out some way to do such cases. Now, after dividing the nucleus into 4 large fragments, tilting each fragment, and starting emulsifying each fragment from its apex. Because these fragments are very long, the apex is very sharp, and we must make the apex blunt first. In this case, since the rhexis is not large, I have to emulsify most of the nucleus in the bag. If I try to pull it in the anterior chamber, what will happen is there can be too much stress on the rhexis, and the rhexis can be torn at some point. We must be very patient, never hurry up, always take care of the anterior chamber stability, take care of the comfort of the patient, take care of the head posture of the patient, take care of your centration of the microscope. The eye should be at the middle of the field to get best depth perception. Yes, one heminucleus has been managed. This is the other heminucleus. I come out at this time to inject some viscoelastic substance to protect the corneal endothelium, because I have not used chondroitin sulfate. I have used hydroxypropyl methyl cellulose, and if we inject methyl cellulose frequently, we can protect the corneal endothelium nicely. I'm doing some manual work. There's a small attachment between these 2 fragments, and it has been separated by a Sinskey hook. And now I'm introducing the tip of the phaco handpiece again. After injecting bit of visco, and here goes the tip of the phaco handpiece. The nucleus management part is totally unedited, and you're watching each and every part of the surgery. You can see at this time I'm positioning the head, I'm centering the microscope in such a way that I get the best depth perception. Now I go in again and start from the apex. Most of the part of this large fragment is in the bag. A small part is just supracapsular, and I am at the center of the anterior chamber. where the anterior chamber depth is maximum, and this is the last part of the nucleus, and this is the final fragment, last fragment. You can see how long is the apex, and we can guess that if this fragment tilts, if the apex goes towards the posterior capsule, and if we place the fragment from above, it is just like using an spear which can pierce the posterior capsule. So it is better to tilt these kind of fragments and start emulsifying from the apex. Make the apex blunt first. And now this is the last portion of the nucleus. At this time I remove the chopper, and here after emulsifying some more portion, I can see that the posterior capsule is far behind, but again I remove the chopper, make the anterior chamber more stable, and emulsify the last bit of the last fragment. And there is lot of cortex. We have to remove that. Viscoelastic substance, this is HPMC, is injected. And now I use a 23 gauge Simcoe cannula and remove most of the cortex. The inferior part of the cortex is removed, say from 3 o'clock to 9 o'clock, or say from 2 o'clock to 9 o'clock has been removed. This side port is small, so I ask for the bimanual and remove this superior portion of the cortex with bimanual. Do a bit of polishing of the posterior capsule, and now a foldable intraocular lens is to be implanted in the capsular bag. Most of the patients coming with hard cataracts belong to lower socio-economic category, and they cannot afford hydrophobic lenses. So we use hydrophilic intraocular lenses for them, and these lenses are good. Particularly the Appasamy lenses are very good. No financial interest, but I'm very grateful for the help that I have got from Appasamy Associates. And now this is the final lavage of the anterior chamber. Some visco sticks to the corneal endothelium, and that is removed. And now the antechamber is to be formed very nicely. There should not be any leak from any wound, and then only we conclude the case. At this time I am forming the antechamber and then conclude the case. In such cases, we must widen our vision and look at anterior chamber stability. We must take care of corneal endothelium. We must see posterior capsule behavior. We must avoid any stress on genial. We must see that there should not be any wound burn. And all these things should be taken care of in such cases. So, we must expand our vision to manage such cases. Friends, thank you very much for your attention. Hope this video will help you in developing your surgical skills, be a great surgeon, and serve the mankind with great skills.